welcome back to Neurology 101 on the ProPA podcast. I'm Dr. G, and this is the second stop in our Other Encephalopathies mini-series. Today's topic is a rare zoonotic prion disease that made international headlines in 1990. Bovine Spongiform Encephalopathy, better known as mad cow disease, and its human counterpart, variant Creutzfeldt-Jakob disease. Did you know that variant CJD is the human form of mad cow disease, and it was first identified in the UK in 1996? It's believed to be caused by ingestion of beef products contaminated with BSE prions, and it primarily affects younger patients, often in their 20s or 30s, unlike classic CJD, which affects those over the age of 60. Let's look at the kinder patho. What is BSE and variant CJD? Well, BSE is a prion disease in cattle that causes neurodegeneration and spongiform changes in the bovine brain. When humans consume infected meat products, they can develop variant CJD, a distinct prion disease that shares pathologic features with classical CJD, but differs in presentation and progression. Prions are misfolded proteins that cause other normal proteins to misfold, a chain reaction of neurodegeneration. No immune response and no inflammation, and it's resistant to heat, UV, radiation, and normal disinfectants. So, what is the typical presentation of variant CJD? Some key distinctions from classic CJD is they have a younger age of onset, typically less than 30 years of age. They also have a longer duration of illness. They usually have between 12 and 14 months versus 6 months in classic CJD. They also have early psychiatric symptoms like depression, anxiety, and apathy. In later stages, painful dysesthesias, ataxia, myoclonus, and progressive dementia are found. Death is still inevitable, but it progresses more slowly than the classic CJD. So, how do we make the diagnosis? Well, an MRI of the brain is going to show that pulvinar sign, which is a hyperintensity in the posterior thalamus, and it's more specific for variant CJD. An EEG is less likely to show the periodic sharp waves as seen in classic CJD. CSF tests, we can get that RT-QUIC, which can still be helpful. And the definitive diagnosis is going to be by brain biopsy or autopsy. Diagnosis also involves epidemiological criteria, a history of travel, living in a BSE affected country, especially in the UK pre 1996. All right, now let's look at the treatment. Well, unfortunately, there is no cure. We have supportive care measures only. Just like with classic CJD, we're going to have seizure control, behavioral support, and hospice involvement. Prevention is the key. We want to do surveillance of cattle herds, ban on high-risk meat products like brain and spinal cord, and travel restrictions on blood donors with potential exposure. Now let's look at the book med versus the street med. So book med, we're going to have a younger adult with psych symptoms, dysesthesias, progressive neurologic decline, and you're going to think variant CJD. Street med, a 28-year-old who recently returned from the UK presents with severe depression, hallucinations, and new onset gait instability. You're thinking beyond a psych diagnosis, and you ask about dietary exposures. Good call. So, some quick clinical pearls. Variant CJD has younger patients, psychiatric onset, pulvinar sign on MRI. Classic CJD, you'll see older patients, startle myoclonus, and EEG findings. Both are rapidly progressive, invariably fatal, and prion-based. We want to avoid unnecessary invasive procedures. Prions are very, very hard to sterilize. All right, it's time to test our knowledge. A 25-year-old presents with depression, painful paresthesias, and later develops ataxia and cognitive decline. An MRI shows a pulvinar sign. She recently lived in the UK. What's the most likely diagnosis? Is it A, Huntington disease, B, classic CJD, C, variant CJD, or D, multiple sclerosis? If you said C, variant CJD, you are correct. Remember, younger age, psychiatric onset, and pulvinar sign are classic for variant CJD. What's the most common initial symptom in variant CJD? Is it A, myoclonus, B, memory loss, C, ataxia, or D, depression? I'll give you a few seconds. If you said D, depression, you are correct. Psychiatric symptoms typically precede neurologic symptoms in variant CJD. All right, so some final thoughts. Though rare, BSE and variant CJD offer crucial lessons in infectious neurology, public health, and neurodegeneration. Always think prion when you see a young patient with rapid neurologic decline and early psych changes, especially with relevant exposure history. Next, we'll return to the more common but still serious category of hepatic encephalopathy. If this episode helped make a rare disease stick, share it with a classmate prepping for boards or rounds. And remember, this is the ProPA podcast, where future pros in medicine are made. Until the next episode.